I think the AI is going to be really interesting, Dr. Keating. I mean, there's obviously a whole spectrum here of what we could do for the tonsils. I mean, for example, manipulating them, for me, it's always an important teaching point not to ever do something outside that or inside the arachnoid so that peel surface is violated against the tonsil and the brainstem, because that's where you're going to get the scarring, or particularly between the tonsils where things just adhere. But just describe a little bit about the AI. I think that's going to be a fascinating way to level the playing field, because obviously what Paolo does is more aggressive. But Paolo, you've talked about the sub-peel technique and that sort of thing, so there is still a peel boundary. So that's another variability. It's not just tonsils in and out. It's how we take those tonsils out. And that peel boundary is so important to protect that lining. Can you talk about that a little bit?
As Jerry has pointed out, the brain has many different layers in it. And one of the basic tenets in neurosurgery is to maintain and respect those layers, the integrity of those layers, whether it's a tumor or the cerebellar tonsils. And as you start going outside these boundaries, you put the patient at risk for a healing process. And as you cut yourself, you get a scar as you heal. It's the same thing in the brain. So with respect to the tonsils, there are many different techniques. I think one of the challenges, and I don't want to have the whole audience to press that there'll be no more Chiari neurosurgeons that know what they're doing in the next 10 years. That's not true. I think what's changed in the last decade or more is we've become more scientific about it. We've tried to take out the inherent variables, self-reporting bias, or even just approaching things. You really can't look at this as a single person thing. You have to look at this as a larger context with many institutions, many neurosurgeons. In our data over 25 years, there were 7 different experienced pediatric neurosurgeons. And that's when you start looking at the science of this and take it from an objective standpoint, you start getting the truth. And I think, again, we're getting more and more of this. So back to Jerry's question, what's AI going to do? As we start looking at surgical videos and trying to interpret, what was a good move, what wasn't a good move, and for the record, the residents and fellows are not playing with people's brains or craniocervical junctions. I've been training residents and fellows for 25 plus years. Bottom line is they end up watching an awful lot and learning from you and assisting in very minimal ways. So where no one's playing in there and you're not getting a brand new intern that watched Grey's Anatomy for a year coming in and operating a new brain. But back to reality and AI. AI has the ability of taking a lot of data, 3 hours of a surgery, and then very quickly and easily figuring out where were the good things that were done, where were the bad things that were done, what led to a complication, what led to a better outcome. And you can't do that. If anyone's ever edited a video, even if it's your Christmas video or your Thanksgiving video, it takes a long time to take a 40-minute clip and bring it down to 2 minutes, 3 minutes, because no one's going to watch 40 minutes of you toasting your friends. So AI has the ability of taking all this data, compressing it down, and looking at things that were good and things that were bad, and then using that not only for review, retrospective review, but also for training purposes and for planning ahead and trying to figure out, maybe if we were more sub-peel in this dissection, the tonsils would have had less of an issue. It's an interesting time frame for medicine, and the volume and the size and amount of data out there is just mind-boggling, and so that's where AI hopefully will come in to help us with this.
Paolo, any comment about specific
I'm going to first answer your question about the PIA. So the PIA is the saran wrap, which is around the nervous tissue, and if that thing is violated and you burn you burn while you coagulate the tonsils, you violate the PIA and some burned or injured tissue comes out. At that point, you're going to have something called tissue necrotizing factors, which are going to create an inflammatory process, which is going to lead to additional adhesions in the area. Although we found that the blood was the major determinant over the years, out of our several hundreds Chiari revisions we had done. Now that said, there is a way to shrink the tonsils, keeping the PIA intact using certain kind of power on the bipolar coagulation. If you want to resect the tonsils, you don't want to leave behind raw areas. So otherwise, again, you're going to have massive amount of tissue necrotizing factor being exposed to the CSF. So what we do is we coagulate the outside of the tonsil, respecting the pia. Then we make a small hole in the pia itself. We burn inside the tonsils, otherwise the tonsils remains medium rare. And then we suck all the dead tissue out. At the end, you're going to have the equivalent of a paper bag, which is empty of its contents. And then we stitch the paper bag together to each other. So you're going to have not only a shrunk tonsil, but an imploded tonsil with respect to the pia. And we stitch the pia opening to itself with a very small stitch. So at that point, you can do a tonsil resection without leaving behind something which is going to create shrinking. That said, obviously, what my speech was both provoking and provoking. I like to poke. I like to throw hand grenades on the thing. As I said at the end, I'm very open-minded about the fact that all techniques do help, and the more aggressive techniques should be the product of individual growth, which comes from the accumulation of experience, etc. And at the same time, the techniques are not totally equivalent.
Paolo, we're going to see if there's any questions from the audience. Anyone have any comments on this? Yes, ma'am.
Thank you. This message is for Dr. Bolognese. Could you identify the location of the Chiari centers in New York?
Oh, right now, top of my head, those are in New York, guys. One in Columbia, one in NYU, one is at Cornell, one is at Northwell, and the other one is our Southwest Center. So these are 5, and before you blink, there are going to be 2 more.
Yeah, good question. Other questions? Anything you've been wanting to ask about the tonsils, but been afraid to ask? Anyone know what the tonsils do? Someone can ask that question. Yes.
Actually, there was an answer coming from an article from the University of Munich. There were the ENTs and the neurosurgical and neurological department. They did a paper together, and they did something very German. They were measuring the electrophysiologic action on the tonsils, and they track it down to some sophisticated mechanisms of equilibrium. So the assumption was, okay, so if you cut the tonsil off, something's going to happen to your balance. So they went in and they cut only one tonsil and they left the other one alive. So the other one alone. So then they redid the electrophysiologic and they found out that there was 0 effect on the balance performance. That said, personally, I would never do aggressive manipulation of the tonsils of somebody who, for example, is a circus artist or somebody who relies a lot on, abnormally elevated balance skills, because I do not know, maybe in that case it would make a difference. But in normal folks, removing the tonsils does not take anything away.
Thank you. Yes, ma'am.
So it is not a dead piece of tissue, that's what it is.
So
Thanks, Paolo.
I think the understanding now is that tonsil herniation length does not correlate with symptom severity. I'm one of those rare ones that had no herniation. Mine went sideways, elongated, tips were white from compression. I actually saw Dr. Bolognese twice. You didn't do my surgery, but you confirmed my diagnosis. If they're working with the Cavalier King Charles Spaniel to enlarge the hypoplastic posterior fossa, make that larger, then making a larger space by opening the dura, shrinking the tonsils, to me is beneficial. In my case, my neurosurgeon was not considered conservative, but at that time he did take partially one, left a little bit the other, kicks himself now for it. But I had 0 spinal fluid flow to the back. After surgery, I did have it. I had neurally mediated hypotension before surgery. blood pressure is 50/20 within a couple minutes of being raised on the tilt table. After surgery, completely normal. So I fight for people that don't fit the typical descending, because mine couldn't. My opening was incredibly small. But I think the important point that was made, and having worked with the Chiari community since the late 90s, is putting your hands in with an expert, to trust them to do these complicated things. When you do open and you have complications, they know what to do when those things arise. So I personally found a huge benefit from having mine opened and having some resection of the tonsils.
Yeah, great point. Thank you for sharing that. One more question, anyone? Yes, front.
Hi there. Thank you both. I was also a bath plug cerebellum. Tonsils were kind of like a bath stop. My question is, I know you were talking about AI, and thank you so much for your disclosure on like the statistical analysis being complex. I was wondering, with this being such a multifaceted variable situation, when you do your testings, a lot of time we hear about making it more objective, as you've discussed. Do you consider EEG testings along with MRI as far as like pain cycles go, or in POT situations with your high heart rates? Because so often we hear that if you have POTS or you have pain issues, it's like psychological, psychiatric, and I think we're finally getting to a breach of it's not necessarily about picking what or separating, it's more merging. How can we help? Like the surgical side of thing has, I think, been on the forefront of that and listening to patients and advocating for them. But I'm just curious, do you work with people that read EEGs ever to maybe learn about receptive properties?
Yeah, I think the hard part on all this, and again, as a pediatric neurosurgeon, I see more often a very different patient than the adult Chiari neurosurgeons. We have a paper that's been in production for about a year. We've got to get it out there, and it's just about done, looking at our kids that are hypermobile with Chiaris. And again, you already know that 2% of the population have a Chiari, don't even know it, so it does exist as an incidental finding. When we look at the kids that had hypermobility, and again, you can define that any way you want. It's a dysautonomia, it's connective tissue, it's immune. I mean, you all know what these issues are, and everybody's different. And I have families where there's 4 kids that will have it, and every kid's different. And some kids have the worst looking MRI you've ever seen. They'll look perfectly fine without symptoms. Other kids' MRIs aren't that bad, and they're terrible. And so everybody's their own textbook. But when we look at the kids that are hypermobile, and again, back to the science, and they're operated on for the symptoms that are felt to be related to the Chiari, they do just as well as the other kids. Sometimes a little bit longer, but the same outcomes, the same morbidity, and all that sort of stuff. When you look at kids that had surgery for different reasons, and again, the symptoms for hypermobility or EDS mimic a lot of the Chiari stuff, and you have to separate the forest from the trees. It's a challenge. But back to your question about EEGs, there may very well be part of that. I just don't think people are sophisticated enough to kind of look at the bigger picture to figure out how much that has to come into it. And it's not a psychiatric issue, and patients come in all the time being told they're crazy. They're not crazy. It's an issue that we don't understand. It's multi-systemic. You got to look and figure out what's Chiari related, likely to be, and what's not Chiari related before you decide to do something. And back to the question about science, the more objective it can be, the better it's going to be. And we look at the tonsils. Doesn't matter how low they are; it matters how tight it is. And we're looking at CSF studies. Some of the guys in this room have been involved with that, trying to figure out what's normal and what isn't normal. And again, of course, every one of you is different in here, and you're probably going to have different CSF flow patterns than other people as well. But the trick is to figure out when does it become abnormal for that patient. And then once you know that, then to be able to define or at least target your therapeutic approach to that problem, and not just to the same operation for the same X-ray picture.
Yeah, great thought. Very good question. Well, thank you. Please thank our Paolo.